All right. So myocardium, that's the actual muscle. That is what is actually doing the work when we talk about contraction of the heart. Um, as far as the tissue goes, you guys looked at this in AMP1, striated. It does branch, intercalated discs to allow for electricity to pass cell to cell. Okay? Lots of mitochondria so that it can work. It's constantly working. Right? Myocarditis, this is something is causing inflammation of the tissue. So typically we talk about these are cardiomyopathies. There's several types, and the functionality of the heart will decrease with any of these. So this is why when you play sports, you're always going to get physicals beforehand. They're listening to the heart. The one they're looking for is hypertrophic cardiomyopathy, and HCM. If you've ever seen the movie John Q with Denzel Washington and the kid collapses all of a sudden, or there was like Six Man where the guy dies all of a sudden. Anytime you hear about an athlete suddenly like dying on the field kind of thing or during a sport, typically means they have HCM. There's several genetic issues there. They do have to get a heart transplant. There's actually no other solution but to do that. Okay, its efficiency of pumping blood just decreases, and they essentially have a suddenly the heart just stops, it arrests. All right. So as far as the myocardium goes, lots of myoglobin so it can pull the oxygen off the hemoglobin, lots of glycogen so we can have lots of energy. It can use any source, fat, high energy, so it will burn through that primarily. All right. So I'm going to switch to the camera and we'll go from there. All right. Is share content, camera. All right, so we're gonna do some stuff on the board. I did do it with whoever's in my lab. I did show you guys this, so we're gonna run through it again. So I apologize for the redundancy for some of you. So when we're learning the heart, there's several things we need to know. One, flow. So the heart is a box, okay? Um, with this box, we need to remember patient's right, patient's left. So we have right atrium, left atrium, left ventricle, right ventricle. The heart is a pump. It is referred to as a double pump, meaning when the bottom squeezes, the ventricle squeeze, the atria are relaxed, and then vice versa. Okay? That's how we're working. As your systemic, this is lung. Okay? So we're gonna start, I like to start in the left atrium. Left atrium is oxygenated blood, and here is oxygenated. We're gonna send it through a doorway here. The doorway is a two-valved structure. So I put two lines here, and then it's attached chordae tendineae. The two-valve structure is the mitral valve or bicuspid valve. Okay. And that term mitre, the mitre is the hat, the Pope's hat. That's where that comes from, the two like flat pieces, right? So we send oxygenated blood into here. When this valve opens, why does it open? First, the chordae tendineae. When the ventricle relaxes, you pull on the chordae tendineae, it pulls the valve open. Immediately, 70% of the blood just falls in. Okay? 70% just right in. Then we're going to send it to the systemic. When the ventricles contract, chordae tendineae release, door slams shut. That slam shut We're going to say both of these, okay? That slam shut is your lub. When you talk about heart sounds, lub is S1. Okay? The valve that is opening here is the aortic semilunar valve. This vessel, big grand vessel, is the aorta. Oxygenated blood to the body. It'll circulate through the body and become deoxygenated. Deoxygenated. What we're going to learn is it really doesn't lose too much of the oxygen. You're going to lose like 5% in reality. That's why you can hold your breath and not immediately die. Okay? When it's deoxygenated, we send it back to the heart. That's a horrible arrow. This marker is dying. Any better? This is going to represent inferior vena cava and superior vena cava. Superior is draining the upper body, inferior is draining the lower body. Returning it to the heart. We open a door for him. There's no valve here. It just dumps in to the right atrium. Now we need to send it to the right ventricle. This door is the tricuspid. 3 valve, or 3 flaps on the valve. Okay, same thing, chordae, tendonae. When the ventricles relax, 70% drops in. When the ventricles contract, both doors shut, there's lub. We pressurize, and to open these doors, the pressure inside must be greater than the pressure outside. This valve, let's just do that. This valve is the pulmonary semilunar valve. PSV. This vessel, it's deoxygenated, but this is pulmonary artery. Because it's going away from the body. It's still an artery, or sorry, away from the heart, not away from the body. Away from the heart, but it is considered deoxygenated blood. We'll go through the lungs, we'll oxygenate. Now we return oxygenated blood to left atrium, open a door for him, and this is pulmonary vein. Even though it's a vein, it is oxygenated blood. Okay? So that's circulation. Just put the chat here in case anyone asks something, I can see it. All right? So when blood pushes out here, eventually we push all the blood out of here. We can't maintain that pressure. The pressure outside here is now greater. The vessels accommodated, they stretched. That's why we feel pulse. Pulse is heart rate. What's happening is, as your heart is pumping the blood into your body, the vessels get a surge of blood in them and they expand. That's pulse. That's what you're feeling. Okay? The pressure in here is now greater than in here. These doors will slam shut. When those doors slam shut, that's your dub. That is S2. Okay? Whenever we talk about systolic and diastolic, we're referencing, in reality, we're typically, what we're talking about, if they just say systolic, diastolic, we're talking about the ventricles. If they say atrial systole or atrial diastole, then we're being specific about here. Systolic is working. Okay, the muscle is contracting. Diastolic is rest. So, in here, This is ventricle systole. This is ventricular diastole. When you go to the doctor and they're listening to your heart and they say, take a big old deep breath and hold it, the reason is when you take a big old deep breath, you compress the capillaries in here, you increase the pressure in here, you do an S2 split. You can actually hear the pulmonary semilunar valve and the aortic semilunar valve separately then. So if there's an issue, we can hear it. Okay? Heart sounds are hard to hear. It's a skill you learn over time. Investing in a good stethoscope is worth it. I always tell students, get a Littman. They're expensive. They're like $150 starting, something like that, but they have a lifetime warranty. And get your initials on it because stethoscopes have a crazy phenomena where they grow legs and walk off. Okay. And don't leave your stethoscope hanging from your rearview mirror unless you want your car broken into. I mean, drug addicts see that and they go, oh, there's prescription pads in there or there's medication samples in there and break into cars. Also ruins the rubber on it from the sun. Don't leave your stethoscope hanging from your car or in your car. All right? Or your white coat, stuff like that. It's just asking to get broken into. Don't do it. Also, when you leave, like, as a student, you leave, like, lab coats in your car, stuff like that. People think laptops are in the car when they break in for it. So, yeah. Actually, I had a student, one of my students, it just happened to them, like, 2 weeks ago.
You?
KSU. Her laptop got stolen and all her books. Not cheap. How about it happened to me in med school while we were in the house? Me and my roommates were in the house at night. We're studying in one of the bedrooms. And one of my roommates went to the bathroom. And as he's walking back, he hears a noise coming from the kitchen. And he looks and some guy is standing in our kitchen over like our kitchen table grabbing stuff. He runs into the room. We lock the door. We call some friends to come. And they came and he stole one of our roommates' backpack. It had like his PSP in it, books. Took it while we're in the house. And people are brazen. But yeah, he was gone by the time our friends showed up. It's wild. All right. So, what makes your heart beat? Do you like think about it and it makes your heart beat? Hmm? Say no. There are a pack of cells here in the right atrium called the SA node. The SA node is the pacemaker of the heart. It is what decides that your heart will beat and the speed it will beat at. So when we talk about SA node, when he beats 60 to 100 beats per minute. Your book or the videos may say slightly different, that's fine. That is what is maintaining your resting heart rate. If you start to have more activity, it speeds up. You get healthier, it slows down. So you talk about people like Lance Armstrong, the cyclist guy, and I think his was like in the 30s or 40s, and that is normal for him. As Dr. Casey last week when we were in lab, and he's a runner. His is 53. It's just because he runs. So the efficiency of the heart pumping is greater. The ejection fraction. That's what we're going to talk about. The cardiac output. How much is pumped out every time is more efficient. Okay? So SA node fires. It sends signal into here, through here, and we hit what's called the AV node. The AV node's purpose is to slow down the electrical signal. And the reason is we need the blood to flow. We need the blood to shift into the ventricles. So AV node, if the SA node is not working, it will take over. He beats 40 to 60. So patients will have heart attacks like in their sleep or something, not know it. It takes out the SA node. they'll come in and they'll be like, when I walk to get the mail from the mailbox, I'm like winded because the heart can't accelerate the blood around the body enough to oxygenate the tissue. So they feel fatigued, winded, okay? The next area we go through is the bundle of His. Bundle of His typically beats 20 to 40 beats per minute. They can come in and still be alive, but this is tough. This is very, very tough. And then lastly, we go through Purkinje. So Purkinje wraps around the entire ventricle. So Purkinje, this is not sustainable with life. It's usually like 10 to 20, somewhere in there. It's not sustainable with life. So when people have heart attacks and the SA node fails, that's when we put in a pacemaker. A pacemaker now is sending that signal. If the SA node is firing, these don't fire. They just relay the message. All right? EKG. What we're measuring with EKG is electricity. That's all we're measuring. Deflection of electricity. So when SA node fires, that represents T wave. This flat spot here represents AV node. Then we get QRS. Yeah, like having a moment. Is that right? I feel like that's not right. If I have the Q, if I have this in the wrong area, someone tell me. Okay, that represents contraction of ventricles, very big. Then we have T wave. T represents relaxation of the ventricles. So this is atrial depolarization. That is the electricity traveling through the atria. QRS represents ventricular depolarization. That is the contraction through here. And then T wave represents ventricular repolarization. That is the relaxation of the ventricle. You'll notice I didn't write atrial repolarization. I feel like that's wrong, and I don't know why. Let's see. Let's see. Tell you, sometimes brain just shuts down. No, I'm right. Okay, I'm right. Brain is just having an argument with itself, all right? So we don't see atrial repolarization. It's happening, but it's here. This is so grand, this is what we see. It overrides atrial repolarization. So that's why you don't see it on EKG. Okay? Cool? This is basically all of heart, all right? And then I always like to share the story. So I have SVT. I discovered it 5 years ago, like 5 years and 2 weeks, okay, from now. SVT, I have a secondary SA node. So as we age, your SA node starts to slow down. You look at older people, it slows down. You look at babies, they're way, way over there. And then as we age, it slows down, slows down, slows down. That is normal, okay? So as mine slows down, my secondary SA node started firing. So what happened was that weekend, I got sick, I had the cold, and I took Sudafed. Sudafed is a big no-no for people with SVT. It has pseudoephedrine. It's a stimulant. So I did that. And then Monday, I went to work. I had coffee in the morning. I came home, I had coffee again, and we went to the gym. My wife and I started working out, and I felt like my chest, like quivering. I thought it was muscle, and I touched my chest, and it wasn't the muscle quivering. It was my heart. I went to take my pulse. I couldn't get my pulse. It was too fast. So max heart rate for a patient is 220. So a newborn, max 220. That's all we should ever see. When you start exceeding these numbers, you run the risk of heart attack. See, what we're going to learn is coming off of here are small vessels that feed the myocardium. We feed it during diastole. When this relaxes, these doors close, there's a back pressure that flows through those vessels. So if you shorten diastole because your heart's going too fast, you're not feeding the heart tissue. So I couldn't get my pulse, and I was starting to turn pale. A brown guy turning pale is kind of weird, right? And I'm starting to cold sweat. And so my wife notices it, and she had just gotten the Apple Watch, and it has the EKG on it. So she put it on, and like you hold the crown, and like it'll start showing it. And I saw it, and I was like, that can't be right. So I stopped, and then I did it again. It was right. It clocked me. So at the time, I was 35. So my max heart rate should have been 185. I was at 232. That is wild. Okay? That if I had poor coronary arteries, heart health, I would have had a heart attack. So in that situation, how do they deal with this? They do what's called an ablation. You may have heard of ablation. They go in here, they look for the electricity passing through the alternate pathways, and they fry those cells and kill the pathway. Downside, they can actually take out the pathway for the SA node. You have to put in a pacemaker. The other option is beta blockers. Beta blocker drugs like propranolol slow heart rate. The downside to that is the heart can't come up to the speed that it needs. Beta blockers are one of the hardest meds to keep patients on because of how they feel. They feel like crap. They're trying to go upstairs, they can't. Okay? They're just winded all the time. And then in males, it also adds erectile dysfunction on top of that. So you get like younger males, you give them a beta blocker, and patient compliance is horrendous. Okay. So yeah, I had to do a stress test. Oh my Lord, so much fun. Right? But yeah, so for me, in the end, they told me if I can't convert after 30 minutes or I pass out, then we have to do ablation. That's where I'm at. And how I convert it is vagal stimulation. So vagal stimulation can actually have an effect on the heart to slow it. So ice water. Ice water or bearing down can be sufficient to stop an SVT episode. It's kind of wild. I'll show you guys my EKG. Let's see, stop sharing. I have it here somewhere. Usually keep it on my computer. Yeah, here it is. Okay. This is what we captured off of my wife's Apple Watch. That is 1 second of time. That is 1 beat, 2 beats, 3 beats. There's about 4 beats per second. That is wild. Right? Something genetic, just born with. You will see a lot of SVT. SVT, it's just, there's tons of people with it. So my wife, she went to work, and at the time she worked on the pulmonary thoracic floor, and she, oops, that's not what I need. And she showed that to one of the cardiologists, and he's like, I have to see him immediately because it's high risk. And Tuesday morning, I came here and I felt like crummy. It started to do it again. So I grabbed Dr. Casey because he was in lab, and I was like, "Can you take my blood pressure?" And it was insanely high, because cardiac output is increasing. Anytime the heart pumps faster, cardiac output is going to increase. So I got it to calm down, and then I drove myself to the hospital. Stubborn, right? I got it to calm down enough to where I felt fine to do that. And the best part was like my wife is texting me like, you have to come. I'm booking you, an appointment with the cardiologist for like tomorrow. You have to come. I'm calling her as I'm pulling into the ER because I don't want to panic her. And then she starts yelling at me because thinking I'm saying I'm not gonna go, typical guy, right? Um, but yeah, I walked into the ER and I was like, I'm pretty sure I'm having an episode of SVT. Pretty sure I had one yesterday. And they're like, do you just have an ID? And then the triage nurse is like, room 6, wheelchair now. I mean, they rolled me back instantly. And within seconds, there was about 15 people in the room because the risk of heart attack, you get a male coming in saying anything heart, and they like jump on it. But they did all the tests, everything. Normal, fine. But yeah, you'll see a lot of SVT. All right. You guys can go through this. Use what I did on the board to help orient yourself as you run through the images. Okay. Here they're showing the two semilunar valves, and then there's our tricuspid, there's our bicuspid or mitral. Valvular stenosis. When we get older, the aortic semilunar valve will develop stenosis. Around 65 years old, everyone will have some form of stenosis there. Why? It is seeing the highest pressure constantly. Every time your heart beats, it's seeing that high pressure. So it hardens over time. That's normal. So sometimes we'll pick up a secondary sound here. We'll get a little extra sound here as the blood is starting to pass out of the the ventricles, and we'll pick up a noise here. That's normal. We're not worried about that. If you have a patient that is an IV drug user, you're going to see endocarditis and valvular stenosis in them because they're not cleaning their skin, they're injecting, bacteria gets in there, it attacks the heart valve, potentially destroys it, they potentially need replacement, and you'll see valve stenosis in them. And then there's rheumatic fever, autoimmune, it misidentifies the valves, it attacks them, you'll see it there as well. Okay. Did we talk about the valves last week? I can't remember. I don't think so. So, replacement options for valves. They can actually do a pig valve, that's the most common, or they do a mechanical valve. The mechanical valve destroys red blood cells, though. It's like the hemolytic. So yeah, you can see either or. Mitral valve prolapse, you typically see this post MI. And what happens is the chordae tendineae become weak. The muscle dies, the papillary muscle that's holding a chordae tendineae. And so when the ventricles contract, the mitral valve sees extra pressure and you get some fluid going back into the atria. So they're not circulating like they should. Depending on the amount of regurgitation, they may have to do a valve replacement. Sometimes we give like calcium channel blockers, beta blockers, stuff like that, and we can mitigate it through that process. Right. So heart has 4 chambers. Atria, that's where the blood is entering into the heart. Ventricles, that's where blood is leaving from the heart. The right ventricle is referred to as the pulmonary circuit. Left ventricle, systemic. It is a pump, pumps back up. So, hopefully y'all can still see can you still see the board decent, or do I need to put the camera? Like on the screen, can you see it decent? Put the camera. We'll switch to camera. Okay. Zoom in a little. So, it is a pump. If this portion of the pump fails. It doesn't pump fluid forward. It also doesn't accept the fluid behind. So if your left ventricle fails, what happens? Backs up into here. Backs up into here. Pulmonary edema. These patients will come in because of the excess pressure in here in the capillaries. Fluid is shifting into the lungs. So when we talk about lung structure, this is the alveolus. These are simple squamous. Air is coming into here. On this side, capillary, 2 to 3 simple squamous cells right here. Fluid, because the hydrostatic pressure in here is so high, pushes into here. So they come in, and you can gauge how bad their pulmonary edema is by how many pillows they use. They start to elevate themselves so the fluid will kind of pool and they can breathe. If not, they're coughing. They feel it. You can find protein in there. They'll cough up usually like a viscous, kind of whitish fluid. That's pulmonary edema. What do? We got to decrease blood pressure. This is where you start to see use of like diuretics. We need to pull the blood pressure down so we don't push pressure into here. We'll slow the heart, those beta blockers, because cardiac output will decrease and pressure will decrease. This is actually what Viagra was created for. That was the original use. The side effect was dealing with impotence, okay? But actually, sildenafil, that's what it originally was created for, which is pretty wild. Pulmonary edema. All right, what happens if this fails? Back up, systemic edema. This is where you see swelling of the legs. You ever see someone that has like purple around their ankles, stuff like that? They have congestive heart failure. That is that pooling of blood, bruising, all of that because the pump isn't working. That is a direct sign of it. What's going to make the pump work harder? What makes your heart work harder than it needs to? Anyone at home? Anyone? Energy. So if we are working out, yeah, it's going to work harder, but it actually increases efficiency. It's good for it. Like cardio, it's good for it. What is it circulating? What's in your vessels? Blood. What will make your blood harder to move? Vasoconstriction. Vasoconstriction is a good one. You start constricting vessels, it's not going to move too well. What if you harden the vessels? Arteriosclerosis. So that's what happens, with high blood pressure over time, it hardens. With high cholesterol over time, it damages it and hardens. Your heart has to pump harder. Clots. Thick blood. We talked about polycythemia. Polycythemia. Viscous blood. Harder. More vessels. Why would you have more vessels? Why would your body create more vessels, more capillaries? If something's blocked, we can develop what's called neovascularization. You could grow more. What if you grow? The larger the body, the more vessels. The more vessels, the more resistance. The more blood, the more the heart has to work. Okay? So in obesity, we see heart failure for that reason. Right? Some populations, African Americans, they typically are susceptible to arteriosclerosis of the renal arteries. It's very common in them. It's all arteries. So African Americans just naturally tend to develop high blood pressure, even though they may be skinny, healthy, all of that. It's something genetic. So in that situation, we use the water pill, HCTZ, hydrochlorothiazide. Okay. In certain patients, when they have congestive heart failure, that's where we use Lasix. Lasix is a loop diuretic. We'll talk about that when we get to kidneys. It drops crazy amounts of fluid out of the body. Okay? Very, very fast. All about dropping blood pressure. The problem is you can't drop too much because if you do, you will not perfuse tissue. Loss of perfusion of tissue, the tissue will die. So it's a balancing act with that. Typically, first drug of choice for dealing with blood pressure is lisinopril. Lisinopril is your go-to. And what that does is, we're going to learn about it, dilates the vessel that is entering the kidneys and increases your ability of your kidneys to function and get rid of fluid in the body. Right? So systemic circulation, left side of the heart is pumping that. Pulmonary circulation, right side. Double pump, so that is like that, okay? Artery, vein. And it's always going to go from high to low pressure. We're pushing into the low area. So the aorta, that's going to have the highest. Lowest is SVC, IVC. That's returning. It's gone through the whole system. As we go through the arterioles and capillaries, we decrease pressure. It just plummets. So here they're just showing these images. Guys, go through it. So arteries are always away except for, well, sorry, arteries are always away. All of them are oxygenated except for pulmonary artery. Veins are always towards the heart. They're always deoxygenated except for pulmonary vein. There are some in fetal circulation we'll talk about, but that's it. Okay. Saw that. This is what I ran with you on the board. This is the flow through all the vessels. The added thing on here that they talk about is coronary sinus. That is when we're feeding the myocardium, and after we've fed it, that is the venous side of that, and that is just draining that blood. Okay, but everything else, it's what we ran through. It's just in the words. You can go through that. Same image. All right. Here, the nice thing to show here, this is chordae tendineae. There's that papillary muscle. So as the ventricles relax, you can see how it's pulling. And then as the ventricles contract, that pressure builds up and we close it. So if there was like mitral regurgitation or prolapse, what happens is this valve ejects up into the atrium and blood goes up into there when it shouldn't. So here, this is semilunar valves. So as the ventricles contract, pressure is now greater than in aorta or greater than pulmonary artery, blood will leave. When the pressure is then greater in those two vessels, the doors will slam shut and we'll start the cycle all over again. Here, this is the actual supply to the tissue itself, to the myocardium. So there's aorta, and we can see vessels coming off of it. So we have right coronary artery, left coronary artery, circumflex, goes all the way around, like circumnavigate, okay, go all the way around. Anterior interventricular artery, I learned it as left ascending. No. LAD. LAD. Left ascending. Wait, that doesn't make sense. LAD. Yeah, it's LAD. Man, blanking today. I'm telling you. What is LAD? Anterior. LAD. Left anterior descending. Yeah. I was tell you, the brain today. Okay, so a lot of books will refer to that. That is the widowmaker. That vessel, if it gets clogged, you choke off right ventricle and left ventricle. Okay, both will die. Widowmaker because we're not pumping any blood anywhere. Okay. The marginal branch can create what's called an anastomosis. It can be connected in people. It's kind of a safety net. A buddy of mine, a few years back, I called him. I just can't get a hold of him. It was kind of odd. Couldn't get a hold of him for like 2 weeks. All of a sudden he calls me and he's like, so I've been in the hospital. I was like, dude, what happened? Like, what's going on? He was out like pulling a tree, started having chest pain. Got his wife to drop him off at the hospital. They start looking. He has a 100% blocked anterior intraventricular artery. His saving grace was he grew a vessel that bypassed it. It had slowly grown over time, and that was his saving grace. He probably had a connected marginal artery too. He felt some slight chest pain, discomfort, went in, ended up with that. They put some stents in, and then a couple weeks later, they went in and cleared the LAD. Skinny guy in his 40s, right? But he has, genetics. Typically, in this situation, it's either genetics or poor diet. So when we have high cholesterol in our diet, it damages the lining of these vessels. You start to build up the plaque, it occludes it, heart attack. Okay, so that's why like monitoring cholesterol levels is very important. Just because the way someone looks does not define cholesterol level. So I have like genetic high cholesterol. Mine was like 232 or something, 230, something like that for LDL. No, the cholesterol is going to damage it and block it over time. It builds up the plaque and slowly occludes it. So what happens is in your vessels, so it's your vessel, it starts to damage the cell here. This creates turbulence. So our blood should just flow through. Now when it strikes here, it goes like this, and on the backside, it's like a dead zone. So eventually this builds and builds. And then what happens is there's a slight gap. And the patient will come in and say, when I'm doing yard work, I get chest pain. That's angina. What's happening is there's not enough supply for the myocardium when it's working harder. So what do? We drill it out and we put a stent in. Stent is like a tube to hold it open. It's a drug-eluting tube so platelets can't stick to it. What drug do we give them? What do they take for when they have angina? They get chest pain. See them all the time. Just pop it. Not aspirin. Aspirin is very good for if they're having a heart attack at the moment, they chew it up, take it. But nitroglycerin. Nitroglycerin is the only medication you'll ever find that will not come in a safety bottle. It is a quick pop top, so they can take it in the moment. Nitroglycerin, vasodilator. So it'll open it up and allow them to have proper blood flow if they're having angina. Okay, so that is in stable angina that we talk about that. You need to do a bypass. A bypass, the vessel is blocked, so they'll take usually the great saphenous vein from the leg, and they'll build a bridge across, like around the vessel. So like in this example here, they would bypass it. Like my buddy just had a natural one form. Some people, it happens. But yeah, the problem with bypass surgery is veins are not designed to deal with the pressure. They eventually harden over time and can fail. It's a limited like fix. Quadruple bypass. The Widowmaker. It happens. You'd be surprised at how often you catch like during an EKG or something. And that's why it's important, like preventative medicine, you do stuff like that and we verify it's there and we catch it early. It's easier to fix early than go back and deal with a heart attack. Because once you have a myocardial infarction, that's the proper term, tissue death. Once this tissue dies, the heart dies, that's it. You cannot repair it, right? So efficiency of the heart decreases. My dad back in the day, he went to the gym with me and my buddy, and one of his friends came who's a physician. My dad passed out after doing cardio. At the time, I didn't think anything. Like I didn't know. I was an undergrad, and the physician was like, "Oh, it's probably just because you didn't eat well, and that's why you passed out." No syncopal episode should be ignored. You should find the reason. It is not normal for people to pass out. The only time you're going to say, okay, maybe it's normal, typically young female will have that happen to them because they're growing and they haven't like replenished blood volume enough compared to the rate that they're growing, and menses, and you can see it in them sometimes, like a petite female, okay? Petite male too, technically, but usually the female more common because of menses. No other syncopal episode should be considered normal. There is a reason for it. Well, fast forward a little bit. My dad feels a little funny from time to time. It was angina. Goes in for an EKG, a stress test, and the cardiologist is like, I think there's something there we need to go look at. Goes in while my dad's on the table, like goes in and looks at the vessels. And he was, I believe it was 98% blocked on one of them. So while he's on the table, they put a stent in, saved it. Had it continued, and that's it, he stressed it enough one time, MI, and we'd be telling a different story. Okay? So stuff like that, preventive medicine, important. All right. Venous drainage. So this is after we supply the heart. We have all the different vessels here, and then eventually coronary sinus into the right atrium. So ischemia, that is low blood supply. That's typically when you see angina. That is that complaint, the chest pain. It can be diffuse. It depends on the patient. Okay? Women tend to complain of reflux. That is the pain they typically say. Males, it's in my jaw. I feel like an elephant is sitting on my chest. It's in my arm, stuff like that. If it continues and there is not enough oxygen supply to the tissue, then we have the myocardial infarction, MI. Permanent cell death, efficiency of the heart permanently decreased, and it's a very dangerous time because we need to remodel the tissue. The first 2 weeks post MI are incredibly dangerous. They can go into VFib. VFib is the ventricles are just pulsating randomly and they're not pumping blood properly. That is potential death. Okay? That is, you have to shock, you have to restart the heart. That is potential death. And then because we're remodeling the tissue, they can actually have what's called a free wall blowout. They can actually their heart will literally rip wide open. Blood will go into the pericardial sac. Cardiac tamponade will happen where it compresses the heart and they can die. So MIs are no joke, right? So here, this is where they went in. They used contrast, and they can see that constriction right there. So in stable angina, we give nitroglycerin. So my dad makes for some great stories sometimes. In church one day, my dad's like a deacon, so he sits up front and everything. And he had nitro. And his cardiologist also goes to our church. Okay, so his cardiologist is there. And during the sermon, all of a sudden, my dad, like a genius, he had some chest pain, took a nitroglycerin. You're supposed to wait, I believe it's 5 to 10 minutes before you take another. He didn't get relief right away, and he took another. All of a sudden, they hear him gasping for air. His blood pressure tanked. They had to call 911. He had to go to the hospital. And then they find out, his cardiologist comes with him, finds out that he took that many pills, and he's like, just give me that back. He took the nitro from him. Okay? Great drug when used appropriately. So my dad doesn't get any nitroglycerin anymore. All right. Here is SA node, AV node, bundle of His, They also call them bundle branches, bundle of His, and then Purkinje. So as this is coming down, whoops, the ventricles will squeeze, and they squeeze like bottom up to push as much blood as they can out. Okay. So SA node, it's the pacemaker, and we're going to talk about what makes him contract. It's just like muscle. Sodium comes in, and we have what are called leaky channels. I think they also call them funny channels, constantly leaking sodium in because the heart wants to constantly be able to contract as needed. As we reach threshold, the sodium gates will open. So sodium is coming in. As we reach threshold, we'll fire. We'll see a plateau due to calcium, and then we'll see repolarization due to potassium. The heart cannot undergo tetany. Tetany is not possible. If the heart contracts and doesn't release, we're not pumping blood. So tetany is not possible. There's an absolute refractory period of time where the heart cannot send another signal. It has to repolarize and come back. Tetany in a heart is what you see when like someone gets electrocuted. That's what's happening in that moment. Electricity coming through and it's making the heart contract and just stay contracted, and potentially disrupting this signaling process, stopping that and stopping the heart. Okay. There is no nerve control of the heart. It has its own SA node. Acetylcholine does not play a role in here. And like we said, the SA node, it sends action potentials. It should be 60 to 100. No one just sits at 72. Okay. All right. So here, this is what I just drew on the board. This is due to sodium coming in. This is due to calcium. We need that hold so that we can move the blood. We don't want to just be a fire and that's it. And then the repolarization. This absolute refractory period, this period right here, that's where we cannot have another signal coming through and contraction. When you start to alter people's ions, electrolytes, this is where you get that wonky stuff. So when I went for my SVT, for example, I think my calcium, it's a range of 3.5 to 5.5, something like that. And I was like 4 something, and the cardio was like, no, I want to see your calcium higher, or potassium. Sorry, it was potassium. I want to see your potassium higher, because that could have triggered the SVT potentially. Okay, sodium levels altered, that's a problem. If you inject someone with potassium, it stops their heart. That's what lethal injection is. It's two sedatives and potassium. If outside the cell is very high, potassium can't come out, heart contracts, we put it into tetany and it stops. They use the sedatives to stop the breathing center. And so it's not like a painful situation for them. That's what they do. So AV node slows it down, and we're slowing it down so we can let fluid move. Then we go into bundle of His and Purkinje, and the ventricles contract. So SA node, the myocytes here, they're real big so that we can let it fly through. Versus the AV node, thin and few, so we can slow down that electricity pulse. It's like a big wire versus a little wire. The amount of electricity through the SA node, big, fast, data flying, versus small wire. Okay? It's like cable and dial-up. Oh. All right. All of them are without neuron innervation. There's no nerve controlling this. SA node, he sends out the pulse. Everyone just transmits it. If he fails, then the others start to take over. So SA node, pacemaker, it'll speed up or slow down depending on the demand of the body. Okay. So rhythm problems, tachycardia, too fast. So SVT is supraventricular tachycardia. Above the ventricles, something is sending signal to make it fast. VFib, ventricular fibrillation, it's just randomly contracting, not survivable. You can't like just go into VFib and bounce back. Like you've got to be shocked and stuff. Or they stop your heart. They give adenosine. Adenosine will stop your heart temporarily. They'll put you into asystole, flatline, and then you'll come back. Okay. So when you talk about heart, pacemaker, SA node, sodium comes in, plateau because of calcium, and this allows it to have a long refractory period so it doesn't send another signal, and then repolarization, potassium leaving. We must have repolarization. We must have relaxation. We cannot have tetany. Whereas the skeletal muscle, it's just sodium, just potassium, and they can have tetany or this constant state of contraction. Saw that. EKG. So P wave, there's that atrial depolarization. Between P and Q, that's AV node. QRS, that is ventricular depolarization. And then between S and T, we've completed that depolarization. T is repolarization, relaxation. These are showing the electricity. These are not showing where the blood is moving. The blood is delayed. So when you talk about like P wave, in reality, the contraction of the atria and blood starting to move is probably like mid P wave. It's kind of chasing it, okay? Don't confuse those two. EKG just represents the electricity. So here, they kind of spell that out for you. So like here's P wave, atrial contraction starts after that. Somewhere in here, we see atrial contraction. PQ, that is atrial systole. That's really right in here, especially the end of like P, mid P to Q, the atria are contracting. We hit AV, we stop, and we go through QRS, ventricular depolarization. Somewhere about midway through here, we actually start to see ventricular systole, contraction of the ventricle. Atrial repolarization is happening in there. We can't see it because the electricity from the ventricles is so grand, so big. So it just kind of covers it up. They say it's buried in the QRS. That's typically how they reference it. T-wave is relaxation or repolarization of ventricles. And we'll just start all over again. If you really want to learn EKGs, I mean, we do it in lab, so I'm not going to really go over it here. You can count QRSs, and from there you can figure out heart rate. So typically we do 6 seconds of counting, and then you count how many QRSs, and you multiply by 10. That gives you over a minute how many beats per second. But yeah, if you really want to learn about EKGs, there's a book. It's an orange book, and it's by, his name's Dubin. A very simple book to read. Images. It's an old book. It's I think from like the 80s or 90s. But like you walk into a lot of physicians like personal offices, and you'll see that orange book on their bookshelf. Okay, it's Dubin. So they go through all the different rhythms. So here's normal. So we have P, QRS, T, P, QRS, T, P, QRS, T. Here, there's no P wave. SA node is dead. So this is where the AV is taking over. There's your 40 to 60. Here, second degree block. So we go P, QRS, T, P, nothing. There is a block at the AV node not allowing the signal to go through. There's even third degree block. There are different variations of this. So in this situation, they end up with a pacemaker typically, if it's real bad. And then VFib, and there's that grossness. It is not survivable, like I said. We have to reestablish rhythm of the heart. So post-MI, people are at high risk of going into VFib. or post-trauma. There was one in the news not too long ago about the football player where his heart stopped on the field. That's what happened. He went into VFib and it stopped when he got hit in the chest. So when there's trauma to the sternum, if it is hard enough and you just tap the heart, that's all it takes, can be sufficient to send them into VFib and stop their heart. It kind of like just knocks it out for some reason. My father-in-law, the week before our wedding, someone ran a red light in front of him. He T-boned him. He was in an older Suburban. They don't crumple. Older cars don't crumple. That's not a good thing. You want your car to, when you're in a car accident, you want your car to be destroyed. That's what you want it to be totaled. If it's doing that, it's absorbing the energy and you're not absorbing the energy. You look at like new cars and I mean, they're obliterated after a minor accident. That's a good thing. Old cars, they're like tanks. They hit it. They don't crumple. They don't reduce the energy. You absorb the energy. So that's exactly what happened to him. He hit the car on the B pillar, which is between the doors, very strong spot in the car. His seatbelt, the car didn't take the like energy out. And when he compressed against the seatbelt, he fractured his sternum. So he had to stay at the hospital overnight I think 2 nights, because there was fear that he could go into VFib. So I had him hooked up on an EKG and they just have to monitor him for a period of time because there is that risk. So you can see it in situations like that as well, right? Auscultations. So this is listening to the hearts. We talked about lub dub. Okay. You're always listening in the direction of the blood where it's traveling. And really, mitral valve, I always learned under the armpit here is a better location for it because of how the heart is turned. Okay. So the sounds when the atrial valves close, so that is mitral and tricuspid, that's our lub. When ventricular pressure becomes great, that's what's slamming them shut. So as the ventricles start to contract, we release chordae tendineae, AV or the tricuspid and mitral valve slam shut. There's your lub, there's your S1. Dub is ventricles contract, contract, contract. We push the blood out, pulmonary artery and aorta. When the pressure in them is greater than in the ventricles, semilunar valves slam shut. So your aortic semilunar valve and your pulmonary semilunar valve. When they slam shut, that's S2 and dub. Okay. So there are other sounds you can hear. S3 can be considered like normal. You see it in like elderly people and like athletes, young children. It has to do with like stiffening of the wall and like volume of blood. And so when it slams into the ventricles, you can hear it a little bit. S4 is considered like anomaly. And then there's tons of noises between all of those that you can hear. Dubin goes through those. So if you're interested in learning it, like I said, good book. Okay. So pressure. This is showing all the different pressures in the compartments. So when the ventricle is contracting, we see the pressure increase. Eventually, we open the semilunar valves. Pressure is escaping. Eventually, at this point, pressure in the aorta and the left ventricle are equal. We start to backflow and slam the door. There's S2. Okay. Here, little pressure in left atrium, and we get, as we start to contract the ventricles, the AV valves closing. There's S1. Whoops. All right. Diastole and systole. So remember, whenever they just use generically diastole or systole, they're talking about the ventricle. Diastole is rest. So, you know, people will always say, well, what's your regular blood pressure? And they always say 120 over 80. And it's usually somewhere up to 139 over 89 is considered normal. Either of those numbers break above that, you have high blood pressure. The top number represents systole. The bottom number, diastole. How do we measure it? it's about sound. So, and we cover this in lab um, for you guys, but say this is a blood vessel. So we put a cuff on it and we compress it. When we compress it, this comes down here like this. There's no blood flowing through here. As you start to release the cuff, blood will start to come through and we'll hear a sound. That is called the first sound of corticough. That is your systolic number. So I always tell students, if I always crank it up to 200 and then I start to release from there. If I hear sound immediately, you take the cuff off and you're supposed to call 911. Like if you're in a clinic, something like that. Because they are in a hypertensive crisis. They can literally blow a vessel out at any point in time. So it's a very dangerous thing to be playing with. They need to be seen immediately. As we continue to release the cuff, we go back to normal. There's no turbulence in here. There's no sound. So when the sound stops, that's technically the second sound of corticough, and that's your diastolic number. If diastolic is over like 100, it's the same scenario. You should be immediately sending them to the hospital. Okay. Very dangerous situation. Also, the machines are horrendously off. They're notorious for that. I've seen machines be off like 20 points. Unless it's like one in the hospital, like a real one, I wouldn't trust the machine. They're very, very inaccurate. Okay. So as far as let me see where we're at. Let's stop there. We covered a lot today. This is a good stopping point. Any questions? All right. Work on heart. We'll finish it next class. All right. And then we're going to do blood vessels, I believe, next. I will see y'all. Email me if you need me. Bye.